is it Francesca or Francis to give us the opening song? Is Mercy available to give us the opening song?
Yeah, Sister Marian, we are trying to play the video.
Okay, all right, thank you.
Always right. Mr. Maya, may we carry on? We are finding it difficulty to play the video, so we can carry on.
Oh, okay. Okay. Right. Anyway, without further ado, then we have the privilege to have in our midst a colorectal specialist nurse, and she is in the person of Rebecca Chichoi-Hu, and she will be presenting to us bowel cancer awareness. If you have any questions, you can drop it in the chat box or you can raise your hand. So without further ado, I will hand the platform over to specialist nurse Rebecca.
Hi, everyone. So my name is Choi Cheese, but you can call me Rebecca.
Okay.
Can you hear me?
Yes, we can. Yeah.
Great. Let me just try and share the screen. Is it working?
Yes.
Yes.
Yeah.
I'll just go on there. How do I? Let me move that out of the way. Right. Can we all see the screen?
Yes, please.
Great.
Yes, we can. Yeah.
Brilliant. So just a little bit background about myself. So I was qualified over 10 years ago in the UK. So I started off in the orthopedic. So about hip and knee replacement, and then I joined endoscopy. So it's all about camera tests, camera for the stomach, camera for the bowels, and camera for the lungs. And then I became a ward sister at a very, very busy acute surgical ward. So anybody emergency abdominal surgery, like an appendix, or if they had a bowel obstruction, they will come to my ward after the operation. And then just before COVID, I was blessed to be given this job as a colorectal triage specialist nurse. So my main role currently is to telephone patients and I get referrals from the GP. Hang on. Close. Do I close the breakout room? Cancel.
No, please. I think there are some others who will be joining in there.
There's a breakout room in progress. So do I just close it? Hang on. I can't get rid of it.
Please, you can continue with it. There are some
but
people who are not okay with the language.
Let me just move it out of the
translation
way
for them.
because it's blocking my screen. Okay, let me move it there. Okay, Right, so so if patient go and see the GP with bowel problems, they would get, some patient would get referred to the hospital as a 2-week wait referral, and I would receive the referral on the computer screen, read every single one of them, phone the ones that is suitable for a camera test or a scan. So this is my current role, and from this role, I have obviously gained a few experience of what signs and symptoms that people need to look out for. So what is a bowel cancer? So bowel is the large bowel, so the large intestine, which consists of the blue arrow, which is the colon. And then also we've got rectal cancer. So they all consist, all together is called colorectal cancer. Next. So just some statistic. So this is taken from the Cancer Research UK. Male, the highest cancer is prostate cancer, and then we have lung, and then we have bowels. For females, it's 30% breast cancer, lung, and then bowel. So even though bowel is like third, but it's still one of the biggest cancer found in the UK. So just a little bit tailored to your group. Hang on, this is in the way I can't read it. So for Black people, generally, they do have a lower risk of having any sort of cancer. However, they do have a high risk of stomach and prostate cancer. I haven't looked into why this is a problem. Possible because of genetic, but obviously we need to look into it a little bit more, but that's not my speciality. So this was taken from the gov.uk. There is quite a lot of statistic about age, different areas, but there isn't a lot of statistic about whether Asian, Chinese or African, how much cancer they're getting. So it's a bit hard to find this data. So moving on. So there are different possible causes of bowel cancer. So majority, we would find cancer in over 60-year-old plus people. Diet, so we do find a lot of cancer, especially in American, because of the diet. They have a lot of processed food, they have a lot of red meat, not having a lot of fiber, which can cause a high risk of causing any sort of cancer, along with overweight, if you're not very active, and if you drink a lot of alcohol, and if you smoke a lot, not just because of this, these are the risk factor of causing bowel cancer, it can cause other cancers as well, and also family history. So I do get a lot of referral with bowel symptoms and also family history with, for example, oh, my grandma had cancer, my auntie had cancer, but this is not first degree relative. So if it's a family history of bowel cancer, it needs to be a first degree relative. So for example, me would be my parents, and they need to have had a diagnosis of cancer before the age 50. So if they still have cancer like at 69, it will possibly be because of other factors and not a family genetic problems. So next slide. So signs and symptoms. So there is a few signs and symptoms I've listed on here, and we'll go through a little bit more details in with regards to some of the topics. So main signs and symptoms is changes in bowel habit, any blood in the poo, abdominal or rectal pain, and significant unplanned weight loss. Now we're talking about not a one or 2 pound in a week. This is not too significant, and we need to have make sure it's unplanned. If the joints are slimming well, obviously we are not taking that into account because they are planning to lose the weight. So anything is significant, like 1 stone in a month, that unplanned is what we call a significant unplanned weight loss. Incomplete evacuation is when you go to the toilet, you've emptied your bowels, but you still feel like you've not done a good job. You still have it more to go, but you've not managed to pass anything else. So it's what we call an incomplete evacuation. Any lumps or bumps in your tummy area, any signs of anemia, and also signs of obstruction. So now we're going to go into changes in bowel habit. So what does it mean by changes in bowel habits? Have you had any changes in your frequency? So very often we have patients saying, I used to go very regularly, once every morning, but more recently in the past few months, I'm going like 6 to 10 times a day and is very, very loose. Or I'm not going at all for, and it would take about 3 to 4 days before I actually manage to go. So this is what we call a change in the frequency. Change in consistency, as you can see on this lovely chart here. So from 1 to 2 is a bit constipated. So you need to have more fluid, you need to have more fiber. 3 to 4 is what we like to see, the ideal type. 5, 6, 7 is what we call looser stools to diarrhea. So soft blobs, fluffy, not formed, or proper water is what we call type 7. So any type of stools, any changes, you need to report or just keep a diary to make sure that whether it will go away in the next few weeks or is a consistent, is not improving, then make sure you let your GP know. So next, about blood in the poo. So what we call PR bleeding, parectal bleeding. So any bleeding is unusual. So first of all, I will ask the patient, what is the blood? What is the color? Is it bright red or is it dark? Is it on wiping? So if some patients just have blood on wiping, which can highly likely due to piles like hemorrhoids. And is it streaks of blood outside the stools, or is it pink or red that would color the water bright red? Or can you actually see the blood that is mixed with the stools or the diarrhea? Or is it very dark or is it black? So we don't really like to hear when patients have black stools, because that means that they have some sort of bleeding on the higher up upper GI tract. So from the esophagus, food pipe to the stomach, by the time they digest all the blood, the poo will come out black. So it's very, very important that they get seen quickly. So next is abdominal or rectal pain. So I've listed a few, all these possible pain and problem and the possible reason for that. So first of all, bloating and passing more wind. So a lot of patients may complain of feeling very bloated after food or bloated all the time, or they're passing a lot more wind than normal. It could be possible because of a food intolerance, or they've developed IBS, or is it possible trapped wind? Our next one is they're feeling very full and very bloated after food with heartburn and feeling sick. Could it be indigestion? Sometimes they might have quite a bit of cramping. Is it because of the bowel, like IBS, as we said before, or is it because of period, or because of some sort of food after you've eaten it, you'll get cramps? Sudden onset of lower right-sided abdominal pain. Is it because there's a problem with your appendix? And if you do have severe pain lasting a few hours, central to upper right side, could it be a gallstone? So all this pain and problem may not be always related to the bowels, but obviously sometimes it can be. So bad ongoing pain, which goes down to the groin, and you're feeling very sickly, and pain when you pass in urine, it could be because you might have a kidney stone. So when you have pain and discomfort in your tummy area, it may not always be because of your bowels, but it's always better to get it checked out. So signs and symptoms of anemia. So anemia is a very big factor of what we check as well. So especially iron deficient anemia, with us checking and looking at the ferritin levels, because if you do have a possible tumor or any worrying signs inside your body, these growth needs a lot of blood and supplies of blood for it to grow and for it to spread. So we that's why we look out for anemia. So any signs of anemia could be dizziness. Are you feeling dizzy all the time, or is it when you sit down and stand up you feel a bit dizzy? Are you very short of breath? Suddenly you walking up the stairs, that is taking an effort and you're out of breath. And are you feeling tired all the time? Of course, when you have these symptoms, even if you have anemia, it doesn't mean that you've got cancer straight away. You might have any other problems, but again, it's definitely good to go to your GP and check it out. Next, this is a very important one, signs of obstruction. So if you are not able to open your bowels for up to 7 to 10 days, and I have had patient who is in such case, and your tummy is very distended, very hard to touch, you're not passing any wind, and you're starting to feel a bit sick and also vomiting. So that means that you may have a possible bowel blockage. So that means somewhere in your bowels is a bit blocked, things are not getting past, and it's getting all backed up. So when it's getting all backed up is when you feel a bit sick and vomiting. When you don't have any wind in your bowels, it means that the actual bowel is just not moving at all. So that is a worrying symptom, and it's very distended again. Nothing's moving in your tummy, and you're not opening your bowels for 7 to 10 days. You must go and see a doctor straight away. On a weekend, even just go to A&E. So I'm going to give you an example. I spoke to a patient about a couple of weeks ago, so in all these signs and symptoms, but the only thing is he was passing wind, and there was a lot of bowel sounds. So I was quite concerned about him, and because he's passing wind, I've requested for him to have a scan straight away. But when you have an outpatient CT scan, it takes up to a week before you actually get the appointment. So I said to him, if you are pain getting worse, because he was getting a bit of abdominal pain as well, and if you anything at all, if you're not passing wind, if you are feeling a lot of pain, vomiting, you must go to A&E. So I went back to work the next day, just check on him, see how he is, whether he's had a scan or any scan date yet. He went to A&E the day he spoke to me, the day after he spoke to me, and he had a CT scan, and the CT scan did show that he had a bowel obstruction, and he had obstructing area in the bowel. He was rushed into a surgical ward, and he had an operation, and we're waiting for the outcome. So it's very, very important, if you have any of these signs, make sure you go to A&E and go to our doctor straight away. So if you have any of the above symptoms for over 3 weeks, do make an appointment with your GP and make them aware of any of these symptoms. So, for example, if you've got constipation, the GP may want to put you on some medication and see how you go first. They may not send a referral to the hospital straight away. They might want to monitor your condition, do some blood tests, do a stool sample, and also a fit test, which I'll go into it in a minute. And they might do an examination just to have a feel on your tummy, check your back passage, make sure there's nothing blocking it, no lumps and bumps, and they need to send an urgent referral to us. But however, some patient may get a 2-week wait referral straight to the hospital because they show a few alarming symptoms. Now, talking about the fit test and the blood test. So the blood test, obviously, we check for anemia, we check your kidneys, make sure all the functions in your body is working properly. Stool sample, there's a couple of samples that your GP may want to send if you have bowel symptoms. One to test for any bugs, and the other one, fit test, is what I want to mention now. So the fit test is what we test for blood. It's a fecal hemoglobin stool sample test. You only need a tiny little bit of stool sample in a stick, and you send it off. So this test for blood, as I said. However, if it's positive, it only means that there is blood in your sample, and there is a higher risk of anything of concerning. And again, going back to the slide about the bleeding, so it can be hemorrhoids, it can be inflammation, it can be a little polyp, a little growth. Majority of the time is benign. And of course, if this test is positive, if it's very high, one of the risk factors is it can be a bowel cancer. So it's important that you do all these tests as the GP requests and send it off immediately. Now, going back to the fit test here, in the UK, I think you get national bowel screening at the age of 55. female and male. So make sure when you get those, do send it off, because obviously they will test it, and if the results come back positive, don't get too scared. Just need to have obviously investigation and find out what the cause of this is. Important to do it straight away. Next. So different type of investigation. So once I review the referrals, spoken to the patient, then in my head, I would assess them to see whether they'll be fit for any of these investigations. Not everybody will need all these tests. So we have like an algorithm and things to follow. So majority of the time, a patient will need to have a colonoscopy, which is a camera examination of the bowels, which is top right corner in the picture in the slides here. So it's a little camera going up from the back passage all the way around the bowels, and we check for lumps and bumps, inflammations, take samples if needed, and any hemorrhoids. We just give a good check out. Now, gastroscopy is the picture on the left. So this is a camera to check your food pipe and your stomach and the first part of the small bowels. So this test is only needed if you've got anemia, if you've got unplanned weight loss, and if you've got like acid reflux symptoms, upper GI symptoms. So that's why not all patients will need this test. And you may also need all the above two and also a CT scan. So following the pathway for Stockport, patient with unplanned weight loss and any lumps and bumps in the tummy will need a CT scan. So CT scan, as you can see the picture at the bottom right, is a polo donut shaped scan. So some patient would worry about having this scan because they've had experience of an MRI scan. So MRI scan is like a tunnel scan, and you go in, it's very noisy, is not a lot of room inside the actual scanner. So patients do get quite claustrophobic and worried about it. So there's not that one that you need. It's the CT scan. It's a donut shape. You just go in and out of this donut shape, and you'll give us a 3D images, because at the end of the day, camera test is gold standard test. However, it can't see any areas outside. So for example, outside the colon and outside the stomach. So we need the CT scan to scan the chest, like liver, gallbladder, small bowels, any area that we don't see with a camera. But different hospitals, obviously, it's got different algorithm to follow. And again, you may not need all the tests. So for a colonoscopy, so briefly mentioned before, what are we looking for? So we're looking for polyps. So we can see that this little grows here, like on like a little mushroom, like a broccoli. So if we do see any on the day, and if it's safe to do so, we will try and remove these polyps like with a little cheese wire safely, take it off and send it off to the lab and get it tested. Like I say, majority of the time these polyps are benign, so it's not worrying. But if we do see any, we like to remove them, because if we leave them alone as it is, in times, many years, it might grow into something that we don't like to see. So if we do see any, we do like to take them off at the same time. We also look for diverticulosis, which is this middle down picture in the slide there. So diverticulosis is little pouches, like little pockets. So these little bumpy bits coming out, it's not like spots, they are like little pouches. So they are very common with age, wear and tear, and it's often caused, obviously, because we don't have a high fiber. So these pockets are called diverticulosis. When these pockets get a little bit stuck, sometimes the poo or feces can stuck in these pockets and cause a bit of inflammation and infection. And this is when we call it a diverticulitis. So diverticulitis is an inflammation, but majority of the time, if it's not inflamed, it's just diverticulosis. We also look for inflammation, which is redness or any bleeding around the bowels. So that's inflammation. We look for any visible blood vessels on the surface of the colon, which can cause bleeding. So I always describe to the patient, it's like a little bit veins, very fine veins that you can see on your skin. So we can see that also in the bowels, and sometimes it can actually leak out blood if you are passing a very hard stool, or it just happens. So that can cause anemia as well. So we look out for any visible blood vessels. And also, of course, we look out for bowel cancer. And different polyp types. So we've got, as the one I mentioned before, like the broccoli one. There's also a flat polyp, so the one that you can barely see, but the endoscopies on the day will be very good at spotting these. There is this one as well that I can't see. Let me just move this box. So there's a raised one. So the raised one and the little one that's dangling. So these are very easy to spot, but we also try and spot flat ones as well. Next. So on a gastroscopy, what do we look for that one? So we look out for any hiatus hernia. So any hernia is an organ that is out of its home. So I always describe a stomach is below, just below your rib cage. And when it slides up into the chest cavity is what we call a hiatus hernia, as you can see on the diagram there. So you've got the food pipe and you've got your stomach on the first picture. However, on the one on the right, you've got your esophagus. However, there's a bubbly bit because your stomach has squidged into the esophagus area, the area there. So that little bit there is the hiatus hernia. So we look for those, and we look for any inflammation again, any ulceration, because ulceration can cause pain, can cause bleeding, and we look for Barrett's esophagus. So Barrett's is the picture you can see on the right. So these are very often we would notice Barrett's esophagus if a patient's got hiatus hernia, because in time, if you're getting a lot of reflux symptoms or the acid keep coming up into this area in the food pipe, it can erode away the mucosa, the area there, and cause little marking. And we like to take little samples on there and make sure that there is no cancerous changes. And if you've got anemia, we also take some samples just beyond your stomach on the first part of the bowels to see whether there's any absorption, malabsorption problems. So next, so like I said before, don't worry at all if you've got some of the symptoms, or you might have all the symptoms. Don't worry at all, because like I said, is don't jump into conclusion. Oh, I've got this, I've got cancer. Take it step by step at a time. Talk to your doctor, talk to any medical team, listen to their advice, have the investigations as recommended, and get an earlier diagnosis. And if we do find anything, then we can try and find a possible treatment outcome for you. Now, talking about the investigations, the gold standard test, as I said before, is the camera test, colonoscopy, gastroscopy, if you need both. Some patients do worried about having these invasive tests. At the end of the day, it is an instrument, very invasive, going inside your body. Now, you can have sedation to make you feel more calm and relaxed during the procedure. And there's obviously the team will look after you very well. But at the end of the day, if you don't want the investigation, you want some least investigations, which is least invasive, which is the scan. We do respect your wishes as well. So but do have a consider and try and have all the investigation as suggested. So I think that is the end. Let me have a look. Yes. And is there any questions? We've gone through that really quick. How do I come out?
If you have any questions, you can raise up your hand, or you can ask, or you can put it in the chat.
How do I stop this? Oh.
Yeah, Rebecca, you can stop the screen, the sharing of the screen. When you look at the top of the screen, you see stop sharing.
Stop sharing.
Yeah.
Oh, there is.
Yeah. Thank you.
Great, thank you. Or was there a hand up? You can ask away if you've got any questions.
We've got a hand up, but I don't know who that is.
I hope if I've not gone through this too quick and is understandable.
Yeah, Tamara, I have a question.
Okay.
Yeah, Rebecca, thank you very much for your insightful lecture.
You're welcome.
I just want to know that once you are diagnosed as having bowel cancer,
Mm.
is it reversible? Can it be treated so that it goes away, or you have to live it for the rest of your life?
No. If we do find a bowel cancer, obviously I am more to do with the front end with the triage, but I do know what happened, like briefly. So if we do find a bowel cancer, for example, if we found one in the colonoscopy, we would take some samples, send it off, and then when the sample comes off, it will be sent very urgently. And we will, once we've got the results, we will discuss your case along with CT scans on a meeting. And then on that meeting, there will be radiology, consultant, everybody will be there to see what the outcome is. So depending on obviously how frail you are, whether you manage to go through a large operation, if you're fit enough to have an operation, and all, again, depending on where your bowel cancer is, more than likely we would do an operation. So we would remove the area of the bowel. So we will remove that area of the bowel, and sometimes we could join it back together there and then straight away. Sometimes we would have to bring a little bit of a bowel out, like a stoma, so the rest of the bowel can have a little rest before we join it back together at the later stage. Now, in between operation, some patient may also need to have chemotherapy, radiotherapy. They might need some sort of chemotherapy before the operation to shrink the area a little bit smaller. So there is a lot of surgical options, but each patient is different. Each patient fitness is different. So we kind of like tailor-made a plan for you. That's why we discuss it in a meeting.
Oh, okay, thank you.
Sorry, I've had to bring those who are translating back in here so that they can also ask their questions. So I'll just briefly summarize this, what you just said. So also for say into about cancer na treatment bi ho bit me aboa and I be and now what you say I so about cancer na nche no ano no na we ye ano no there be on be nche the phone nyina mo twa scan no nyina be ka bom makomu trouble ho na se de me sia aboa say so mu yi free ho ne be ye and I say ye ni nyina no be cause sa ni me nyina mo. That's it. Thank you.
John's hand is up. So I believe John can ask the question away.
Hello.
Hello.
Good evening. Sorry, I missed a little bit of the beginning, but I'm not sure whether my question may have been addressed or not. I'm interested in the prevalence of these bowel cancer conditions and how is it prevalence in the Black community a lot? I've also heard of a lot of meat eaters being mostly being affected. I just want to know how true that is and the prevalence actually in the Black community. Thank you.
Shall I share again? Where's it gone? There. So it is at the beginning of the slide. So I did found some information about the percentage, like the highest percentage in male, and then we had female higher percentage. But like I said before, I did struggle to find the percentage of each ethnicity, I say, what the percentage of bowel cancer in, let's say, for example, Black African or for Chinese people. There isn't a lot of data that I could find in the last couple of days about the numbers. But hang on, let me go back. Oh, hang on. On this slide, it was about so generally Black people do have a lower risk of all sorts of cancer. And again, I think it might be because, as you said, you guys, the diet may be a little bit better. You have more roughage, more vegetables, a variety, and you don't have a processed food. Whereas Western country, and I did find some American, briefly I read about Black American people do have a high risk of bowel cancer. But it was I only skimmed through it because it was like American data. But is it because of the diet? Is it because of the lifestyle? I'm not sure, but it was a bit hard to find actual figures and data about. So this is the actual general data about female, male between 2016 and 2018. And bowel cancer in both female and males are the third highest. It's still quite high.
Thank you. What about the meat eaters? Are they more of a problem?
Yes, generally. We don't say, obviously, I think Rachel and Monica could confirm that with me. One of the consultants, whenever they scope a patient, he would often say, please don't eat any smoked meat or smoked food, because it can cause bowel cancer. So I don't know how true that is, but he always do this. He always recommend us, he always remind us, eating meat or eating a lot of smoked meat, like smoked bacon or barbecue, I presume, can have a higher risk of bowel cancer. And I think, again, that's why Western country, we have a lot of fast food, we have a lot of meat, and that's why we have a higher bowel cancer rate than like Eastern country like Japan and Korea.
Okay, thank you.
Stop that.
Can I ask this question? Being diagnosed with bowel cancer, what is your life expectancy?
I can't give you a true figure again, because like I say, I am the front end triaging. Again, it depends. If you were found to have bowel cancer at an early stage, so again, I think it depends on how quickly we found the cancer. If we found the cancer and it's already gone through your bowels, gone into different organs, obviously your life expectancy with that will be shorter because it's gone through to other areas. Whereas if we do find your bowel cancer to be just very superficially, it's not gone through the bowel wall, it's not gone very far, it's not gone to the lymph nodes, then we remove that area and we bring it back for surveillance and check it in a few years' time. So even though if you've got bowel cancer, we do have a surveillance program to make sure that you go through other scans in however many years, make sure that there's no recurrence. So in the UK, obviously, this is what we're quite good with the NHS.
Thank you.
Okay, can I quickly summarize that? I think the work so we say about any say cancer no ewo tuntun fomu and I say fomu do and I said the na she said o she o kai no tuntun for ne say Asia for ne adendi when share nya figures pa ewo name Black Americans who say omo de ewo mu pa na ni nyina mu no question no saba say na nam no so na so de o kan say I no correct ne mo consultant ba kom ne adwuma de bi o tufo say enam titu de atoto no de so bi edia amana enya bowel cancer onim say no ye no kra na ye no kra, but generally no onim say titu no o gide say tufo de anenta enye nam pisa yentwe na ti e bi ade de kakra na ye ta every vegetable ye vegetables pa yentani anuane a ewo asa ya process ni ade no bebre bag de ane bebre nti question about see answer bu say na bowel cancer no ebo ma so binya bia ya na ne nkwana na ekosai ene wa chem say no ejina bia ehu no si hu ne ntem ene ehu so ne nyan didi nko mia bebre wo honko a eno no ya na umutimi boa umutimi ni chakakra. That's it.
Can I ask this, Rebecca?
Yeah.
Right. I just wanted to find out if I'm young and I haven't got all these symptoms, and I've got 1 or 2. Can I still get screened since the screening age is 55?
Yeah, of course. Go and see your GP, because obviously different GP will treat each patient differently. They may not refer you to us straight away. They still could send you a fit test to do, because a lot of this is what we're trying to promote recently. Since we had COVID, we've been using fit test to prioritize a patient, and then since then we have been the GP has been encouraged to get the patient to do a fit test. So is no harm in asking, do I need to do a fit test? Is there any need? Just to prompt them, really. And it doesn't mean that even if you're young, you've got these symptoms, I won't see you in the 2-week wait. I do see some younger patients, and I do still refer them for the same procedure, regardless of the age, because we do find bowel cancer in younger people as well.
Okay, thank you. It's just a no, and it's not Usa, Nasa, Union, Ufin, when no one being so. And now when you're symptoms, this will train 55 and now someone can test. No, what you say. I so when your symptoms now, if you say, would you pin me quite what RFL am I testing amount and whom patient be brought when you feel when will be and so here I test no a year in your that's.
Hi, I don't know if I could come in
Mariam.
here. I have a sort of a contribution. If I understand what has gone on here so far, then in prevention, we could say we have to reduce our meat intake, red meat intake, and the smoked ones as well. And then if you are able to eat a lot of roughage, like fruits and vegetables, and eat more food that is high in roughage, like our brown rice and our brown bread, it could help us in preventing bowel cancer, if I understand well.
Yes, and also reduce alcohol and don't smoke, because all these risk factor, and also being not overweight, can also help to reduce the risk of bowel cancer. It doesn't mean that you can eliminate it, but you can do your part to try and help your body.
I think we have 2 hands up. Sister Felicia, can you?
Yeah, thank you. Rebecca, I want to know if you're going for colonoscopy and you've been prepared with gastrografin, is it likely that you're going to be constipated after the colonoscopy for some few days?
Say that again.
If you're going for colonoscopy and you're being prepared with gastrografin,
right,
is it likely that you're going to be constipated after the
No.
colonoscopy?
Usually, we don't use gastrografin as a preparation for colonoscopy. So gastrografin, is it to drink?
Yeah.
Yes, to drink.
Yeah, so the gastrografin that you drink is likely for a preparation for a CT scan or a CT colonography. So the CT colonography, you do drink the gastrografin, and it kind of like tags the bowel. So as you digest it into the large bowels, it tell the radiographer what is poo and what is bowel lining. And it has a mild laxative effect, because that scan is the second best than a colonoscopy, but is not as invasive. So the CT scan involves putting a little tube in your bottom puff area, and it gives us images of the bowel. So it's not as invasive as a colonoscopy. But usually, if you are having to have a colonoscopy, you would have proper laxative, oral laxative, and not gastrografin.
Okay, thank you.
Okay.
And to me summarizing just summarize the 2. The first one, the contributions and the cinema pachamucha sabia, the air Kenya, some person be the here pan is over unum cigarette, unumonsa, a face so a num so so na be red meat crowd be free na the yatoton on so pa na nam yatoton they say the ayam tafen barbecue no and so say be intention free mo na you need vegetables no more any the aba ne adeno fruit no so more and ebios no am say wasaka say and say umudu bebre so and so with me ama wenya etimi ya increase risk sɛ wobɛnya saa yare yi so nti ɛso yɛhwɛ yɛ weight so ɛso yie ɛna ɛm sɛ question ba sisi ya no yɛ about sɛ obusa sɛ aduro bi a ɔmo nom no ɛma wonya woyam tim ana na wakyerɛ mu sɛ sɛ aduro no kwa deɛ yɛ na yɛ CT scan mu mpaa na ɔmotaa nom ɛnyɛ colonoscopy no. Yes.
We can see Mr. John Odum, your hands up. Have you got a question?
Yes, please. Sorry, I have to come back again with another question. Becky, what I know is a lot of cancers these days are getting vaccines to prevent them. Is there anything in the pipeline, or is there something at least somebody can think of going for if, say, you have a family history of somebody having such a cancer in the family? Is it clear?
Are you asking about family history?
Yeah,
screening?
say there are vaccinations for some other cancers around. Is there any vaccination for this one, or
No.
possibly in the pipeline that anybody with a family history of bowel cancer can go for?
I'm not aware of any vaccine to prevent bowel cancer, because if somebody do make one, they would make a lot of profit to prevent this cancer. Now, if you are genetically prone to have a high risk of bowel cancer because of the family genes, then you would come back regularly for surveillance colonoscopy. So the only way to check is to do a camera test every so often years to make sure that you don't have a bowel cancer. But there is anything that I know of that can prevent it, as in a vaccine that I know for bowel cancer. I've not heard of that, no.
Okay, thank you very much.
Nti na sabisa no ene sɛ ɔmo aduro bi a ebi ɔmo de vaccine bi a de bɛwɔ na sɛ wonya bowel cancer bi na ya wate sɛ bi ba na ɔse da bi ɔnti bibia na empo ɔmo sɛ ebi wɔ abusua mu ne sa na de ɔmo yɛ ne sɛ afi bia oba na ɔmo de camera awura awase wachi wahwɛ sɛ bi a cancer ne bi kwani bi ba na ne ɔmo hu bi ama wo ɛno ankwa na ɔmo yɛni aduro bia pɛsi ne if it's obinya bisa aduro ne bisa ɛne obinya skapa ba bibia sɛ ne osisi das. Maria, we're done.
Oh, I can't see any hands up, so I think we can now bring this section to a close. Nurse Rebecca, do you have to say anything else?
No, hope this presentation's been informative, easy to understand, and you can share out this presentation if you like, and I hope it helps some people to raise their awareness, and don't be shy, just let your GP know, because no symptoms as a silly symptoms. Let your GP know, and then they can try and help you out. So I hope it helps somebody here today.
Okay, let me take this opportunity to say a big thank you for honoring our invitation. We are much privileged to have you. Thank you.
Thank you.
I will now hand the platform to the next of the program. Thank you.
Thank you very much, Mr. Marian, and thank you very much, Rebecca, for such an insightful